All right, everybody. So thanks for coming to our first Zoom live chat. I think you're going to find that there's going to be a lot of groups that are doing town halls and Facebook Live and Zoom chats like this. And the reason for that is the same reason why we're doing it. It allows for a dialogue, an exchange of thoughts and ideas that can be shared amongst all of us. So as we move forward, and we're going to want to get right to the point and try to direct you towards problem solution, problem solution, problem solution all the way through. I'm going to kind of let Nicole organize the structure of what we do and how we go forward, because it was really her mastermind to work with Matthew on, hey, Brian, we have a podcast where you're putting out personal growth ideas and tips for practice success. We're putting out emails and blogs that are dealing with current event solutions, that people can put in. And most recently, we developed a resource page on our website. And if you haven't been there, you absolutely have to go check out our resource page, because it's going to be a combination of quick video clips of solutions and actions that you can take now, like literally today inside your clinic, that's going to make a difference for your practice. And the bottom section is going to be a complete list of resources that you can utilize that are going to give you the direct source information from valuable resources. I don't know how else to say it, state APTA, national APTA, CDC, OSHA. We have a whole list of very, very high quality providers where you want to get the actual truth. You want to get the actual vetted information directly from them. So we're going to keep that up to date on a daily basis. But this here is a venue that we're going to have an exchange of ideas, thoughts, and dialogues. We will not have every answer to every question. I don't think anybody does. But if we run into that, we are going to take good notes, take that down, and we will get back to the group on our Mastermind Facebook page with the answers, as well as probably if it's something that we have to post on our resource page, we'll post it there. Is that how we're going to deal with that, Nicole?
Yes, absolutely. I think that's the best approach to that.
Okay, great. So we have a little bit of a technical difficulty here. The room ID got changed through our setup time with Zoom to where we are now. So I'm going to just go ahead, and a couple people just wrote in and they need the new number. So Nicole, why don't you tell them about the format of today's section? We got our 3 subjects and we have our Q&A, and kind of let them know this is how it's going to go.
Yeah, and I think the impetus behind all of this came from part of our outreach to all of our clients. And we know that this is very much so a time of constant change and updating of information. So a lot of the questions kind of fell into the 3 different buckets that we have. The first one being personnel management. So we try to categorize all the questions that our clients had, and if one person's asking it, chances are others are dealing with it. So the first topic really comes from that personal management, like what do I do as my patient visits are dropping? And if you haven't had to close your doors completely yet, as your patient visits are dropping, because of this whole COVID spread, how do I manage the downsizing of my staff? So that's the first question, Brian, is first of all, if I'm mandated to close my doors, what can I do? Do I need to lay my staff off? Is it a furlough situation? What is the difference between those 2 things?
Okay, yeah, that's great. And I did have that Q&A sheet up, so I'm going to pull it up on my other computer here in a second. But before I answer that question, I just don't want to be rude. And, we jumped right into it. The technical difficulties threw us off a little bit. What you have here on our call is you have Mike Gorman. He's one of our senior coaches, and he's helping practice owners all around the country. Mike Gorman's a successful practice owner himself from the St. Louis, Missouri area, where he's run and operated multiple offices. And then he worked for a large corporate organization throughout the United States, and he's gained like tremendous high-level knowledge from that experience as well. Most of you know Nicole. Nicole is our Chief Development Officer, and she's the director of all of Meg Academy, and she brings, of course, all the content to you. She's also working with me to co-author a couple of books that are going to be coming out shortly for your benefit. So that's Nicole. And then you all know Matthew, of course. Everyone should know Matthew. Matthew is the media director. He keeps everything going for us between podcasting, YouTube, live, our YouTube channel, everything and anything, website design and development for our practice owners around the country, and marketing direction. So that's the team you see here, and I just wanted to kind of catch up with that. But let's go back to your question, right? Let me just kind of minimize my screen here, Nicole. I was typing into that sheet that you had provided. Just give me one quick second to pull up what you did here. connection questions, right?
Yep.
All right. So the question is, what is the big difference between me? Well, first of all, if I'm mandated to close my doors, do I have an option for handling my staff? Well, my question to you, and Mike, I want to get your opinion, and Nicole, your opinion on that. Mandated to close your doors. First of all, from all the research we have and everything that we know, and of course, state by state, things can change, but physical occupational speech therapy are considered essential services. So I believe if you're mandated to close your doors, it's because you're in a quarantined area, and they have done that to everybody, essential or non-essential, and they're not going to let you open. If that's the case, you have no choice but to either pick furlough or layoff with your employees at this point in time, because you can't even be open for business unless you're going to do some telehealth or something like that. But honestly, I don't think they're going to let you leave your home if you're in one of those ground zero areas. So let's just talk furlough and layoff. Furlough, think of it in this manner. Furlough is a temporary layoff situation. This is where you can actually denote a specific time in which you're going to open your doors back up. You can tell them this is going to be for 2 months, 6 weeks, 8 weeks, whatever you want to do. But you're basically holding the position for the employee to come back to when the furlough is over. While they're on furlough, they can go get unemployment, which is going to be about 70% of their full annual salary, their full regular salary. And you can, as far as our knowledge is, now we could be wrong, different states could have a difference in this, but as far as we understand, you can hold their benefits intact while you're on the furlough. So I'll turn that over to Mike and Nicole to see if you want to add anything more to that. If we're just staying on this answer of furlough or layoff, layoff means they've been terminated, they can go get unemployment, there's no benefits, there's no position for them to come back to. That's a permanent decision.
Right. And furlough can mean different things. It doesn't have to be a complete, shutdown. It could be, you reduce by 2 days a week or,
Good point.
1 week a month. So there is different options when it comes to furloughing your employees based on, again, your caseload and if you're not in that complete shutdown state yet.
Right.
Yeah, I would just, I guess I would comment on the stay-at-home order. So in St. Louis City and in St. Louis County, they've issued a stay-at-home order. However, physical therapy is considered essential. So our clinics in St. Louis do not have to close, but we may want to think at that time of us, in a sense, being triage clinics.
Yeah.
I think the idea of treating a patient if they're post-op or if they're in acute pain, I think that's a great idea. Do we need to treat everyone coming through that door? I would probably say no when you have a stay-at-home order like we do too.
Yeah, that's a good one.
I want to jump in here because we did get a question, and I think this is a good question. It was actually going to be kind of our next question too, that we would like you to answer, Brian. But we have a question that says, if I'm not mandated to close but need to decrease staff, how do I do that for my salaried staff? Do you decrease by halftime? Do you change them to hourly? What is the process that people should be taking as their caseload decreases and they have to downsize versus completely, laying off or furloughing?
Okay, I'm going to try to keep these answers as short as possible, but I also know that there's so many different circumstances. So if you guys have questions while you're hearing us speak, please go ahead, write in the chat, click the chat box, write in your questions. Matthew will read them off. If we need to dialogue with you, he'll open up your mic and we'll dialogue with you. But to answer that question, Nicole, it's what I call a risk-benefit analysis, number one. And number two, it's what is in the best interest of your public and your patients and your staff. So I'll take the second first. If you go to our website and you go to our resources page, we have a link to the CDC and to OSHA. So you need to jump over that bar first, which means you have to prove that you are operating in the best interest of the health and well-being of your staff and of your public by keeping your doors open. Now, we all know that we have a responsibility to all of our patients. Like Mike said, we have lots of medically dependent patients. We have lots of dysfunctions that are going on orthopedically and neurologically that if they were to go untreated, these patients would surely get worse. So can we make a safe, sanitized, welcoming environment to still treat our patients? And the answer to that is, for the most part, yes, you can. You can eliminate your waiting room. You can have people just come to the parking lot and they call in, and then you open the door for them. They don't even touch the door. They come right in. They wash their hands when they come in. They go right to their treatment area. There's no physical contact. You've spread out your caseload, so it's one patient per hour. Each therapist is staggered. Now everybody's outside of the 6-foot radius of each other, and you can make that work. You can have good sanitization, disinfectant policies to allow for a clean environment. You can take temperatures of people who they first walk in. Again, I have a whole tip sheet on that, so I'm not going to read down the whole list, but I think you need to step over that bar first. And if you can check all those boxes and you can look in the mirror and say, I am doing everything, I have no reason to think otherwise, then I think you should move forward, right? If you don't meet that, then you shouldn't be having patients come in the clinic, just, second to none. I mean, I just wouldn't even do that. If you're going to have to now meet the demands, because now your caseload has gone from, 150 visits a week down to 50 visits a week, you look at your part-time hourly staff first. You have to have a conversation with them and let them know they're going to be better served if they're just furloughed, if you're going to have them come back, or if you're going to downsize moving forward, they're laid off so that they can go get unemployment, right? So they can go get those, if they qualify for it. But your hourly staff first. Your salaried staff, you still need some productive salary staff to produce a product. You can scale them back all the way down to the fair labor, what did I write there? The Fair Labor Standards Act, right? The Fair Labor Standards Act. And it allows you to continue to keep them on a salaried position all the way down to $684 a week. So you can prorate your therapist salary down to $684, keep them employed, and still do good by your patients. You can talk to them about making up that money that you owe them potentially later as your funding comes in. And we're going to have a financial section that we'll talk about here. But that's what I would do. I would prorate the salaried people down, and of course, furlough anybody that's way overstaffed so they can go get 70% of their income. Not everyone who's making, I don't know, 75, 80, 85,000 a year can live on $684 a week when they have the ability to get unemployment. So you're going to have to make a call there.
Okay. And I think that's good. And you touched on this other topic. Our next question has to do with essential versus non-essential employees. Mm-hmm. So can you clarify a little bit more about that and how that's relevant to?
Yeah, and I think Mike can offer something here too, because he's worked for big companies, and I'm sure they have maybe a slightly different definition. But, this has nothing to do, please don't get your heart all wound up. This has nothing to do with somebody personally, right? I hate it when people go in and they say, well, I'm worth more than that. And I say, well, everyone's worth $1 million or more. I'd like to pay everybody, 7 figures. This has nothing to do with you personally, but essential, non-essential. Essential means it's required in order to actually produce the product, right? So non-essential would be your marketing staff, potentially some of your admin staff, maybe even potentially reducing some of your billing staff or outsourcing your billing entirely. So you can move forward with that. Essential would be your clinicians, the licensed professional. You can't administer a skilled service without a licensed professional. And the fact is, if I'm a therapist, I can check my own people in. I can actually, do my own tech work. So I can absorb some of those other roles and responsibilities where a non-essential employee cannot absorb my roles and responsibilities. And that's just a good way to think about it. Mike?
Yeah, I think that you explained that well. I think that I don't know if I would say it's the concern I've had or just maybe the worry, because I up until last week, I was still treating. And the worry that we know with the coronavirus is that, at my clinic, we have done a very good job of screening patients. We call them before they come in. We ask the right questions. But the thing is, we know they may not have any symptoms for up to 14 days.
Right.
And so that's the concern. And that's why, yes, we are essential, but I would really like all clinics, and I know it's going to hurt our bottom line for a short period of time, but I think we have to look at triage clinics. I hate to keep saying that, but it was just a fear of mine as I was treating a patient, and I'm a manual therapist as well. And as of last week, there was no CDC guidelines that said that we should be wearing gloves. Wow. So there's just a whole lot of things to really think about. With staff, what I would say is, after you get past your part-time staff, with your full-time staff, I would ask them, do any of you guys not want to be working right now? Because that may help you, because if it's a 3-therapist clinic and 2 of the 3 don't want to work, you kind of have your answer solved there. That's how I would handle it.
Yeah, I mean, I absolutely think that's a fantastic way to approach it. You know, bring your staff into the fold, bring them into the conversation. There's a lot of staff that have working spouses, and they may be like, you know what? She is a single mother, or he is a single father with a child, and he's living paycheck to paycheck. You know what? I can go without for a month or two. I can reduce my hours. I can get on the system. It's okay. But by all means, let's keep this person fully benefited. Let's keep this person on payroll. I see that with our own company. You know, we had to take measures across the board where we reduced hours to 30 hours a week max. And we had to take care of that. You know, we wanted to keep as many people employed for as long as possible. We want to have as least disruption to our staff as possible. And fortunately, we've been making the right decisions along the way to do what's the greatest good for the greatest number of people. But if you have any questions at all on these topics, I would advise you seek a healthcare, a labor attorney, HR professional. If you're on paychecks, refer to paychecks. You know, they'll give you some really good answers there. Contact your CPA, and bottom line, go to your state website, your state government labor website. Each state has one, and just see what they recommend. We also have a furlough versus layoff article that we really liked. Nicole, I'm sure we can link that right on our resource page so people can read for themselves. Furlough versus layoff, and we'll give you that document. It's a very good article, and it just recently was published, like literally last week. So I highly recommend, if you really need more clarity on that, go to our website and go to our resource page and take a look at that article, and we'll put the link up there for you.
Yep. And some of our clients are getting more creative with how they're taking care of their patients. And we had one client in particular ask, if I have a higher risk population person, like maybe an older person, can I provide home health, physical therapy, which we know shouldn't be called home health because that would be Medicare Part A.
Let's call it in-home.
Right, in-home or mobile care. Can I, see them in their home and charge through Medicare Part B?
Yes, absolutely. No, this is wonderful. Like, this is where the experience that we have going all the way back to 2006, we've got a number of clients that are clients of ours that are what we call mobile PT offices. And they're mobile PT because when they signed up with Medicare on the 855I form, they selected that I am providing services exclusively in the home. But what's really interesting is if you go to that 855 form and you go to page 10, I believe it's section 2K, and you look at the first 5 questions there, if you answer question 1 that says no, not exclusively in the home, and question 5, no, not exclusively in the clinic, well, now you're notifying Medicare that I'm not exclusively providing services in the home, not exclusively providing in the clinic, and then you fill out the rest of the form. I haven't done it, but I believe you're going to be okay. Now, this is one of those things where I am not saying conclusively. You need to call your MAC. And you need to say, I'm looking, and you can go online if you'd like. Why don't we put the link to the 855 form as well, Nicole? We'll put it up there so you can download it right off of our site if you wish. Read it for yourself. Make a phone call. That's all it is. Make a phone call and just say, I am a PTPP, a PT, physical therapy private practice. I've been providing services in my home. I'm in my clinic. And at this point in time, I want to provide services on outpatient Part B basis in the home of our patient caseload when appropriate, right? When safe and appropriate. Like in my county, there's not a single known case in my entire county. So it's a little different environment here, not to say that everyone's not distancing themselves and following all the precautions, because we're in the state of Florida, but it's just a little different when you know there's no known case in your state. So it just creates a little bit of a different comfort level and a little bit of different operational basis. But I highly, highly recommend that you pursue this 855I form. And if you need to, you can go on and you can modify your form. This is just me bringing you early information. In another week or two, we may find out, you know what, they're not going to allow both, or you know what, it's totally fine. You're going to have to be the first person to put the footprints in the sand here and just check that out. But I do see a pathway there by using the right documents and pursuing that avenue and see what you're told.
Yeah, and this kind of lends us to kind of get into that second bucket of the things that we want to talk about, which is the
Yeah.
telehealth topic. And you hit on this in the podcast, and I think you did a really nice job in there kind of explaining, especially the e-visit, because that's very Medicare specific. We did get some questions asking and delving into the telehealth portion a little
Okay.
bit more so. So some of the questions that came up are, you know, even if the telehealth services are allowed through a particular provider, do I need to make sure my Practice Act allows telehealth services?
Yes, and that's really good. And I don't know all the states that do not allow telehealth services to be administered. We have been made aware that we believe, and we haven't had a chance to vet it yet, but we've been told by providers in the state of Arizona that Arizona currently doesn't allow for telehealth services according to the Practice Act. Now, of course, I would feel better saying that out loud if I went to the state Practice Act, downloaded it, and read it myself. I have not done that. Mike, have you had a chance to do that?
Yeah, I've just been I've been looking into all the different states that allow telehealth and those that don't. So far, it seems like about half and half, and
Really?
there's many Practice Acts that there's not anything said about it. So my advice is to email the state chapter or give the state
Yeah.
chapter a call, because that's the only way you're going to know.
Yeah.
And because, you know, now that there's a PT compact with Missouri was the third or fourth state in it, and now there's 20 to 25 states in the compact, which makes it easier to get a license or a compact in one of the other states where you can practice. You have to have a license in that state in order to do telehealth in that state.
Yes.
So there's many subsets and laws, and it is, as Brian, you said last week, kind of the wild, wild west. It's vague, but you definitely need to make some phone calls and go online. The APA has a great, they got a couple slides or graphs that show you every state that's in the compact, and then they describe telehealth. So they have some great information.
Yeah, and I want to mention three things on that. And Nicole, if you want to chime in on anything, let me know. By all means, just interrupt me. But number one, please, if you're not an APTA PPS member, please sign up as soon as possible. The amount of work they're doing, those people, Sandra Norby is doing a phenomenal job as our president. She just put out a special issue on the Impact magazine. It literally hit my email about 3 or 4 hours ago, and it is fantastic. They are working day and night to get you the information you need. So please stay connected to PPS. And they're even opening up to non-PPS members to get the same data. So just very generous of them, and I can't support them enough. Mike, you said two things. One was the compact, and I would really love you to explain what that means. Mm-hmm. And two, you have to have a licensure in that state. And I want to clarify it, and please correct me if I'm wrong. My understanding is if I am a licensed therapist in the state of Maryland, and my practice is in the state of Maryland, but I'm doing a telehealth service on a patient who's in Brooklyn, I need to have a license in the state of New York. Even though I'm providing the telehealth service in Maryland, I need to have a license in New York to treat that patient through New York. But here's the funny thing. This is what's benefit for us. And believe me, if you guys have billing questions and how this is going to work, we have a billing company. We do billing for over 100 offices across this country. And this is the benefit we have, because we're not only focusing on operations, we're focusing on reimbursement and billing too. And so we can kind of merge those two. When that billing goes out, you need to put a code in the POS box, the place of service. And it has been instructed or told to me that when you're providing that telehealth service, that place of service is where the therapist is. Where that therapist is. And that doesn't mean, let's say I work for one of those large groups that have 100 locations all throughout the country, and their headquarters is in, St. Louis, Missouri, go figure, right? Well, you don't put St. Louis, Missouri as your place of service. It's where you are. If you're in Maryland or if you're in Texas, even though you work for a company that has a head office in Missouri, you put the place of services to where you are. But you have to have a license in the state in which the patient resides in that you're giving care to. So I answered that side of it, Mike. What's the compact side?
So the PT compact, I believe, started in 1998. I could be mistaken, but I think Oregon was the first state in it. But what it is there is a physician compact, there's a nurse compact, where if you're a nurse in a state and you travel, it's much easier to get a license in that state through their compact.
Gotcha.
It is really good. Like, for example, in Missouri and St. Louis, we're right on the eastern border of the state. Some people work on the Missouri side and Illinois, so it's really good for that. But what it essentially is these right now, I think there's 20 to 25 states have bonded together and they're in one compact. And essentially all you have to do to get licensed in one of the other states is pay your fees, which is typically around $100, give or take. And you have to take a jurisprudence exam, which is essentially your exam to make sure you know what that state practice act is about.
Gotcha.
So
Okay.
you have to do that, but then you have to dig deeper to see, is telehealth allowed in that state? And then unless you're going to go cash pay, are the insurance is going to reimburse you? So there's many layers to it.
Yeah, let's get to the reimbursement next,
And
right?
we have a question that says, where specifically, who do they call to get
For
this
what?
information on, let's see, make sure I'm understanding. Can you describe a little bit more about who they need to call for information on their state? I know each state is different, but
Okay, you don't even have to call anybody. Honestly, you should just go to the state licensing board, like whoever licensed you. Like if it was Maryland, it was the Department of Mental Hygiene. If it's Florida, it's the Department of Health, right? Every state has a board that issues your license. Well, there's a practice act for that state, right? And then you should also contact your state APTA chapter. So I recommend 2 phone calls or go to 2 websites and download it. Like I have physically already created a file where I downloaded the practice act of all 50 states. And so I can go research them, but they're not all up to date. Some were back from 2008, 2009. I think it needs to be redone again. I think that's going to be a good project for Rachel and Kayla, our little research team, to take on. We actually have a research team here at Meg. So we want to be your Google of physical therapy. If anything comes up that we don't have an immediate answer for, or can't put our fingers on, we send it to our research team and they go find it for us. So by all means, if you're a Meg Academy member and you're an executive client, that's one of the perks and benefits of being that. We will find these things out for you so you don't really have to lift a finger. But yes, go to the State Practice Act, Department of Hygiene or Department of Health, whatever, and read it in there, and then go to the state APTA. And then if it's still ambiguous and you still don't have clarity, that's when you make your calls. Make your calls to one of those 2 bodies if you still can't make heads or tails of it. Sometimes it could be a little bit of a jargon in there. But that's that for telehealth. Mike did mention, like, for instance, in the state of Pennsylvania, I believe, and again, I haven't had a chance to vet it, but what we're being told is the state of Pennsylvania does not reimburse commercially, and private insurance companies do not cover telehealth. If that is true, and again, please do not hold me to this. We have not had a chance to vet it. Stuff is just coming in so fast. We will vet it. If that is true, then there's nothing stopping you from providing telehealth on a private pay basis. I don't see any reason why you can't do that on a private pay basis if the insurance company, as long as the state allows it and it's in your practice act, but the payer doesn't, well, now it's a benefit outside of the contracted services that you've contracted with them. So you can go ahead and do that all day long. It's a private pay service. Now have them sign the waiver that you're not going to bill your insurance company. You're not going to bill, they're not going to bill. This is a private pay service and you should be fine.
And then how do we bill for the telehealth services? I know the e-visit is one standalone code for every 7 days. How do we bill for telehealth services if it is, you know, everything verified?
Telehealth versus e-visit. Let's just cover both of those, right? Because it kind of makes sense. So currently speaking, as of what's today's date, March 23rd at 7:38 p.m., right? We are not on the roster as a covered provider for telehealth services with Medicare, but we can do what's called e-visits. E-visits are completely separate. You bill a specific code, G2061, G2062, G2063. That's it. There's only 3 codes. That's it. No modifiers, no 9700 codes. That's it. And what those have to do with is you can provide remote therapy services, e-visit, to a Medicare patient who's an existing patient in your database currently. This is important. They have to be existing in your billing software in your EMR system currently. They can be made aware that you're going to provide, that you have the ability to provide these services, but they have to initiate to you that they want those services. You can't just go and duck, duck, goose and move all Medicare people to e-visits. That's not how this was set up to be. It is at their origination. But you can inform them that you have the services. When you do an e-visit, from the time you start it and you spend some time with them on the phone, it's meant to handle, you know, downturns, confusion, conflicts, you know, resolve problems for them, you know, work them through their challenges and barriers, right? That's what it was intended to do. So you can use now, according to the Trump administration of March 18th, you can use Zoom, Google Hangouts, even FaceTime. I don't recommend it, but you can. And you can work with these patients. At the end of 7 days, from the first time you engage them, 7 days out, you add up the time you spent. If you spent more than 21 minutes, you're going to bill one code, one time, G2063. If you're between 11 and 20 minutes, it's G2062. If it's 10 minutes to 5 minutes, it's G2061. That's it. Game over. You help them. You're going to get what you're going to get. I think I had the reimbursement was jumping between 34.70 or 35.70 for the 21 minute plus, the G2063. And then I think it went down to like, gosh, I wish I had the numbers right here handy for me. It was like $17, $18, and then it went down to like $11 and something like that. So it's not, this is not big money. But if you're going to do telehealth, now you're not talking Medicare, you're talking private. I'm sorry, I'm talking fast. I'm trying to save you all some time. If you're talking private, you need to verify patient benefits. You need to verify patient benefits. You cannot just assume. You're going to contact Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, whoever that private payer is. You're going to verify their telehealth benefits, and you're going to ask the questions, do we have coverage in parity? And do we have reimbursement in parity? You're hoping the answer to those two are yes, because that means the same coverage. Parity means the same coverage applies through telehealth as it does face-to-face in the office. Reimbursement parity, the same reimbursement for the codes in the clinic are going to be the same reimbursement dollars you're going to get through telehealth. Now, several states have it. Other states just have a flat 36 bucks. Telehealth visit, 36 bucks. That doesn't mean, as far as, again, I'm willing to be wrong on this, but as far as I'm caught up and as read as I am on it right now, that doesn't mean you don't still have the normal customary billing of 97,110, 97,112, 97,530, whatever services you did, you're going to have to do the appropriate CPT code, but most likely you're going to add a GT code to it. Some insurance companies were going to ask you to add a 95 code to it. You won't know that until you verify those benefits and you let your billing team know. Now, if you're one of our billing clients, our staff is going to know that. They're going to vet that out. They're going to know that. They're going to inquire. They're going to need your help. You know, who's the patient? What's the numbers? Obviously, it's going to be loaded in the system. But if they don't already know it off the top of their head, they're going to verify it along with you, and they're going to support you on that. But that is the way telehealth works. You use the same 9700 codes, but you have to have a modifier linked to it. But again, some are just paying a flat rate. You got to verify. You just have to verify.
Okay, that's helpful, Brian. Thank you. I think the other question that kind of goes along with that is we work with a lot of clients who utilize a lot of manual therapy or the newbie system, which obviously you have to do that in person. What kind of advice can you give to clinicians such as that may have a hard time with the whole telehealth thing? What kind of advice can you give?
Quickly, you know, I would ask you this. I'm a big manual therapist when I was treating, right? 33 Con Ed courses my first 5 years out of PT school, right? All in manual therapy. And one of the things that I made sure I became well versed in was, if I'm going to do a manual therapy technique on a posteriorly rotated sacrum or an anteriorly rotated pelvis or FSR right L5 or whatever I'm working on, I'm also going to look for the appropriate TheraX program that's going to stabilize what I worked on, or that's going to help mobilize the segments above or below. That's going to facilitate and enhance the effectiveness of my manual therapy. if we're doing telehealth and I can't get there and lay my hands and do the math, then I need to find a self-mobilization way where they're laying on a bolster or a roll and they're actually, or they're going to do standing side shifts and they're going to do some self-mobilization, things like that, right? And then I'm going to find some sort of, posterior leg raises and standing where they're going to work that multifidus and work some stability. So be creative, be thoughtful. I did a podcast with Lisa Chase, and she has a wonderful rehab software program that coincides with every manual therapy approach you have. It has a regimented therapeutic exercise routine that supports that manual therapy. So go back to that podcast 105, check that out. And I think you need to reach out and learn about that service. Mike, I know you're a big manual therapist. What would you say to that? I mean, that's my support of manual therapy in this new environment.
And that's something I've thought about a lot as well. And that's why when telehealth first came out, I'm like, there's no way that I would ever do that, because I feel like I would lose so much. But in light of what's going on now and the way that our healthcare is probably changing, perhaps forever, how many times in the clinic when we're treating a patient and we know a technique, let's say maybe a glenohumeral distraction, a safe technique is very helpful. Well, honestly, there's been times in the clinic that I'll bring the spouse or the significant other over, and I say, hey, you know what? I'm going to show you how to do this real simple technique that I think she really gets a lot out of this, and it would be great if you could do it at home. And you can talk through that. I mean, and you through the screen, because the thing is we want to get our hands through that screen and we can't. Yeah. But you can do some significant other education, obviously nothing complex, no manipulation, but there is some things that you can do to still get the manual therapy focus interwoven in that telehealth visit.
In a question that kind of goes along with that we had from one of our participants here, thank you, Sarah, but it says, if we teach them self-manipulations, can we charge 97140, the manual therapy code?
Well, that's a really good question. Not per the definition of 97140. If you really read it word for word, that would not fall in that category. I think there's 97535 self-help. And I think you need to look at code 97535 self-help. Are you not, in essence, actually teaching that patient self-help techniques? I would make that argument. I would rather see you kind of go in that direction. Mike, Nicole, you guys are both therapists, wizards in your own craft.
I think I'd stay away from, playing with fire, I guess, a little bit, and go with what we know is going to be a more tried and true approach where, your 97110s and,
I just think that's a clinical decision, right?
Yeah, I think doing with something like that, a neuromuscular re-education, I can definitely, you can explain that.
Yep.
Yeah, you can explain that. That's right.
Therapeutic activities, because the other component of all this is you do have to be able to document and support what you've done. So I think
that's a very good point, Nicole. Your documentation needs to demonstrate medical necessity. You need to demonstrate progress. You need to show that you're adhering to that plan of care. Yep. Unlike an e-visit does not have to coincide with the plan of care. It has nothing to do with it. It is to handle a complexity that the patient is experiencing at home. And when you read about e-visits, they're a different beast. They're not like telehealth. So telehealth is in line with the original plan of care. You're just doing it off-site.
Yeah, and we have another question, and just let me make sure I'll read it verbatim just so I don't mess this up. But when billing for telehealth, are you documenting 97110 when you are correcting or talking a patient through the exercise and then adding the modifier?
Well, if you're administering an exercise of any form or fashion, you're at 97110, and the modifier always goes on because it's telehealth.
Yep. Yeah, I think we covered that. Okay.
Yeah, good. I think so too.
Okay, perfect. And I think we have one more telehealth. Nope, I think we covered pretty much. Oh, do we change the code from in-office visit to 0202 for billing purposes for telehealth?
Whoa, say that again?
Do we change the code from in-office visit to 0202 for billing purposes?
When you're doing telehealth?
Yes.
Okay, so the place of service under telehealth should still be 11 because it's where the therapist is.
Right.
If you're saying to me 0202
Mhm.
is indicating that you're doing it in the person's home, then no, that would not be correct. Not from what I've read, not from what I understood.
Okay.
Brian, I think that either I heard it on the podcast or I read it that it's actually O2 is the place of service or the location code instead of 11 instead of
Oh,
11. I'm pretty sure. Don't quote me, but
Yes, I
I'm
think,
positive it's 02.
okay. So if it's 02, then it's 0. It's still to indicate what I may have. Maybe I have the numbers wrong. Maybe it's not
yeah,
11. I mean, that's what I got from the resource I had, but maybe it's 02 that shows that the service was done, from the office. And in essence, the service is done from the office. That's where the therapist is. They're providing the telehealth service from that location.
you have to verify per insurance is the feedback we're getting
Yeah,
from
I
Ally.
would, I would say so.
From
I mean,
our Ally.
yeah, our Ally, our billing
Yeah.
director. So what she's saying, and this is the most challenging thing for us, because we deal with all 50 states and because we deal with every different insurance company and because they're not uniform amongst the states. Blue Cross is separately owned in each and every state. They're not, they're brothers and sisters, but they don't have the same rules and policies. The golden rule is always go back and just verify. And so thank you, Allie, for chipping in on that. Verify your private insurance and
Yep.
see what they say.
It
If
sounds-
you have any doubts and you're a billing client with us, just ask your billers. They're going to know. And honestly, if it becomes an operation problem, they're going to reach back out to us,
Right.
so we're going to help you. And like I said, we have a research team, so we will look up whatever you do need. We do hope that your front desk is verifying the insurance and verifying all of these numbers and then sharing it in the system with your biller. Obviously, that's what our billers do, because our billers don't verify insurance. They actually work with you after your verification to make sure it goes right and it's clean, it's scrubbed, it's good, it goes out the door clean. But you need to have that going on in your office for sure.
Okay. And then I want to shift gears a little bit and get into our last kind of bucket or area of concern that we've heard from many of you on, and that's the financial management area. So obviously that this pandemic has affected many and varying degrees of severity in terms of financial stability during this short, hopefully short time. But what can you talk a little bit about SBA loans and
Yeah.
what they can do proactively? Give a
Yes.
little advice on that.
Yeah. So I'm recommending that all of you tonight, after 7 p.m. tonight, go on the website for the SBA disaster. I believe it's called the Disaster Relief Loan website. The link is on our resource page. You should go there. Sarah, I believe, is on this call, and I believe Sarah knows a little bit about the Seattle market, and she might even be able to share with us. I believe there's some grants available if you're in some of these horrible ground zero type of markets. So Sarah, if you have anything to share and offer, let's throw that out there. I spent all day yesterday, Sunday, filling out the application for the Disaster Relief Loan Program. My understanding is I submitted it all. I went through the whole process. My understanding is that they're going to be able to loan you anywhere between $50,000 to $2 million if you can prove that that money is going to be used for lease, rent, or payroll. Your minimal obligation is a 3.75 interest rate, and you may get a term on the amount that you borrow that could extend all the way out to 30 years. Now, who gets 10 years, 15, 20 years, 25, or 30? I don't know. I assume that's the discretion of the SBA. But the point is, it's a loan application, and it's their standard operating process. Now, when you go to the link on our resource page and you click SBA, you're going to click your state. Once you click your state, you're going to see if you're in a disaster area. When I clicked my state, the whole state is in a disaster area. I think that's going to be true for many people, okay? It's going to start off as a loan, but my understanding is if they ever get their act together and pass this stimulus bill to help everybody out, what may happen, and this has not been a final rule yet, if you do take it as a loan, you do use it for payroll and rent, it may be forgiven during the term of this event. It may be forgiven. You may not have to pay it back. And that's what we're all hoping for. But my advice is get the ball rolling, get the process going now. Your company is the applicant. You are the personal person in the application behind your company. So don't get confused on that. You're not the applicant. The company is the applicant that's seeking help to pay its payroll. Then there's a personal information section and a personal financial statement section. That's all on you, where your money is and stuff. If you're someone like Nicole, there's not enough box width to put all the digits after the amount of money you have in your savings account. So you may have to struggle fitting it all in the box, but just put it in there, fill out your stuff, and then the company, and your company is the applicant. But you got to get it in there, because if they have questions or follow-up paperwork or documentation, they're going to notify you, and you only have 7 days to get them the stuff that they notify you about. So make sure you have an email that you're checking regularly, and get the stuff into them within that 7 days. So get in the hopper.
Sarah is chiming in here to help out to say, if there's grants available in your city that your city is offering, make sure you apply. You know, the process can be tedious and could be months before the relief or the funds can be accessed, but at least get the ball rolling earlier on.
In your city.
So thank you. Yep. So thank you for that, Sarah.
Thank you, Sarah. And those are grants, so that's different than loans. So,
Right.
So that I personally wanted to experience it, and I went through the whole process myself so I could speak to it. So if anybody needs any more individualized particular help, please go to our website and check our resource page.
And I would say that now is a great time for all of our clients to pick up the phone and make phone calls to your credit card companies, to your landlords, to all those people. Don't email them.
Don't email
them, because your voice will be so much stronger than an email. And explain to them that they understand they're going through the same thing. And they may or may not help you, but if you don't ask, you'll never know. Like, I doubt that, I could be wrong, but I don't think a credit card company or a mortgage company will say, okay, no one has to pay for 3 months.
Yeah.
But if you call them, I bet that you have a pretty good chance, with the way the world is right now, them understanding.
Well, Brian, weren't you saying that there's some like Toyota, and you said a couple more were
These aren't cars that you own, Nicole, but I have
a Toyota. Thank you very much.
Yeah, I'm sure. It's called a Lexus, Nicole. So you guys know we like to have a lot of fun here at Meg. So this is not uncanny for us. I had our research team make some phone calls, and what is actually happening is exactly what Mike said. I'm really glad he brought it up. You can contact your car if you have a lease or a loan, and you're making lease payments or loan payments. What we found out was that Toyota, Hyundai, and Ford are currently offering special programs whereby for the next 3 months, you do not have to make a car payment. It can be deferred to the back end of the loan. So you're going to owe the money. You're just going to pay it on the back end. You're going to have some time. If you contact your mortgage company, your bank most likely will have a very similar product. Now, this is coming down from the federal government. They're putting this pressure on these payers to say, hey, give a little relief here. You're still going to get your money. You're just going to get it later. Now, these big major corporations, they can afford that. They can actually live through that. So that is good. And I don't want anybody, don't get me wrong, I'm never, ever encouraging any of you to default on anyone under any circumstances. That is inappropriate no matter what the situation. Own up to your obligations. But ask for compromise. Ask for something that's going to work in your best interest long term, okay? I think many people, at least the people we surround ourselves with, it's not about being just a good professional. It's not about being just a good clinician or just a good leader. It's about being a good human. It's about really like living in the skin of humanity and being a decent human being so that you can take pride in helping another win. And so I think that's a significant piece here. And I'm going to say what Mike said is, I just need to emphasize this again. As a landlord myself, I can tell you, if somebody calls me and we talk about it, it's not expected, it's an ask, and it's a genuine ask, it just makes you want to help out even more. So please do all that you can to reach out and be fair and work out compromises that are in the best interest of everybody.
Okay, I think that's good advice. And we just got a message from, I'm sure you guys are all reading this too, but Sarah just shared that Facebook is also giving out grants, and they had called and asked if there's penalties if they were late on rent, and they said that there aren't any penalties right now. So I think that just reinforces what you all just talked about. So I
That's
think
awesome.
great.
Thank you, Sarah, for that. That's
Yeah.
a fantastic thing. And for those of you that don't have a line of credit, you should be applying for a line of
That
credit
was the
immediately with your bank.
next topic, Brian.
A
Can you
line
talk
of
a little
credit,
bit about that?
get that line. I'm just reading your mind, you know. Line of credit. You need a line of credit. I have always said, I mean, for years, I go into these offices for the last 15 years or 16 years, and I sit there and I'm like, do you not have a line? No, we don't need a line of credit. We do well. I said, that's when you need a line of credit. When you're doing well and the money's rolling in and you're not, that's when you jack up that line. Look, I had 2 PT offices in Maryland. My line of credit was $350,000. I didn't have $350,000 drawn on it, but I had $350,000. And when that crash of 08, 07 or whatever happened, boy, that my company, because I didn't own it at the time, they were glad they had that line of credit because they were able to float whatever they needed to float and pay it back. So all of you should be applying for a line of credit if you don't have one, or increasing what you do have. And here's another little personal secret. If you have an ATM card with a bank like Wells Fargo, Bank of America, or whatever, or I don't know if they even have banks in Wisconsin where Nicole lives, but wherever you are, you
to go to Illinois.
contact your bank and you say, I need to increase my draw amount on my ATM card. Because if all heck breaks loose, you want to be able to put that ATM card into a machine and get more than just $500 out if you need it. You should have some personal cash on hand at home. Not like I was at Wells Fargo today and the guy in front of me is like, could I have $40,000? She's like, well, we can't give you 40,000 like right here. We'll give you 10 now and give you 10 at the end of the week. He's like, that's totally unacceptable. And I'm like, what are you doing with $40,000? Like, if you need that much, I mean, Armageddon has hit all of us. If that's what it's going to take to get through the next 5 days. I mean, it's Monday and he couldn't wait till Friday to get $40,000. But of course, I'm in Florida where it's like, you know, you're senior retired and you got buku dollars and your golf set is worth $5,000. It's like, all right, whatever. I'm just sitting there quietly, like holding it to myself. But be a responsible person to your family dynamics as well. Just have some cash on hand. You know, something reasonable, and increase that ATM limit. Can't hurt. It's just an ask.
Okay. I think that pretty much wraps up all of our questions. We did have a question that was on the topic more of the furlough versus the temporary layoff. And I know Sarah just had to go on. I'm going to email her the answer, but she had asked what benefits are still paid during furlough versus temporary layoff or standby. And my understanding, it's all the same, correct?
Yeah, my understanding it's all the same, right? The benefits stay the same. I do think you have some liberty there. I do. I think that's more of an agreement with the employee when you furlough. Right. So again, this is also fast. So no, you must go to the article, start there, and then of course go to your CPA or healthcare, or I'm sorry, labor attorney, or paychecks or something like that. We will get more details on that and we will post it in our Facebook group. I'll post it in our Facebook group for all of our executive clients who are part of that. I will post it and we can have a dialogue there. And believe me, I've got more podcasts coming out every single week. I think, Nicole, what did we say we're going to focus on this week? I know. Well, go ahead. What did we say?
No, well, you said you were going to hit on the financial thing a little bit more in depth. And then we also want to talk about what actions we can take right now to plan for the very near future, hopefully when we have this dip, but then we're going to ramp way back up and we have to be prepared for that.
Yeah.
Well,
yeah. So I was thinking that what we would talk about is more of the financial implications and what you can do, but I was also going to give some secret verticals that generate more cash-based revenue cycles other than just our therapy, our basic therapy. Because my message before this virus hit, starting in January, my big thrust moving forward in 2020 was you have to get to 20% cash in your GI. Your yearly gross income when this year ends, I want to see 20% of all the dollars that came into your clinic come in through some cash-based service. So I'm going to give you a good 3 to 5 options. And one of them is a cash-based service that has 0 expenses to you. It literally will cost you nothing and it will yield you cash return and a healthcare service. So we're going to put that out in our podcast. So if you guys haven't subscribed, please subscribe. If you need help on how to develop these hybrid models and these cash-based models, Obviously, that's what Mike is here for. Nicole is here for. If you're looking to start up a clinic and you're listening to this, or you guys know people, this is the best time to start a clinic. You probably think I'm crazy saying that. I am not. This is the absolute best time to start a PT practice. You start the ball rolling now. You start getting your training on a startup accelerator program with Meg Academy, Nicole and Mike. I'm telling you, 4 to 6 months out, when your doors swing open, you're going to have the cheapest money. You're going to have the best lease terms. You're going to have the best prices on equipment and supplies. You're going to open up when a robust community of people are looking for services that they've suspended for months on end. I can't think of a better time to get trained up and swing those doors open in another 4 to 6 months. Because I'm assuming this thing is going to turn its corner fairly quickly here. Now, again, if I'm wrong and it's going to take 18 months to turn its corner, we all have bigger problems. So, you know, risking 75 grand on a startup clinic is the least of your worries. I mean, you know, like I said, Nicole's car is more than that. It just never ends. I was holding back. I was holding back most of this show. I was literally
Take it, people. It's okay.
I'm glad it's you and not me tonight. This is great. I'm just relaxed.
Oh yeah, you relax. That's right. Oh, good thing you didn't hit broadcast too early, Mike. It would have been all over you. All right. So thanks for the questions, everybody. Thanks for the engagement. We look forward to it. We're going to continue to do these Zooms. The mistake on the address and stuff with Zoom, we really apologize. We are so sorry for that. It's just one of those things that happens. Zoom is crowded and whatever's going on is going on. We will double, triple check and make sure that does not happen next time. Matthew will put out another email to everybody, and please do your best to get people connected, whether it be with us or whether it be some other beneficial group within the APTA. We all are here to help each other, and that's what it's all about.
Yeah, and I'll just chime in on that. Yeah, sorry for that mix-up this morning during that ID, guys. I will be sending out a recording video tomorrow in your email, so you're going to see this whole recording tomorrow in your email on YouTube. And then I think the next plan is we're going to shoot for Wednesday to do the next live. So you'll get an email just like you got today, and we will double, triple, quadruple check the ID, and we'll send it through 15 people's eyes before sending it out. So appreciate everybody going on Facebook and being active and making sure other people can get in, and I really appreciate that. So thanks for coming in here and making an effort to get in here.
And if there's anything we can do to help you guys individually, don't hesitate to reach out to Jen, JENN @megbusiness.com or info@megbusiness.com. We're here for you guys. Thanks, everybody.
Thank you, guys. See ya.
Thank you.
Yep.